Good afternoon. I would like to present my paper on treatment response of focal laser photocoagulation in onset involving diabetic macular edema. Diabetic macular edema is the common cause of vision loss in diabetics. It can be of two types, center involving and non-center involving diabetic macular edema. Non-center involving diabetic macular edema can be defined as increase in thickness of non-central macular subfields over normal threshold values in at least 2 of the 8 ETDRS quadrants, sparing the central subfield or at least one non-central macular subfield with OCT thickness of more than 15 micrometer above a threshold value. If left untreated, the progression of conversion of non-central to center involving macular edema is 14% at 1 year and 26% at 2 years. Only a few studies have studied the effect of focal laser in non-center involving diabetic macular edema alone, with all reporting reduction in macular thickness and stabilization of visual acuity. In this retrospective study, we evaluated the changes in macular thickness and volume parameters of OCT in patients with NCI-DME, those who underwent focal laser over a period of 6 months. Aim of this study is to determine the treatment response of focal laser photocoagulation in non-center involving diabetic macular edema. This was a hospital-based observational retrospective study. It was conducted at Retina Clinic of a tertiary eye care hospital. Data of 70 eyes were collected over 24 months from January 2022 to December 2023. Inclusion criteria were patients diagnosed with NCI-DME who underwent focal laser with 6 months follow-up, and NCI-DME patients on SD-OCT with less than 320 microns of central subfield thickness and more than 320 microns in one of the 4 inner or outer subfields. Patients with DME of more than 320 microns involving the central subfield, vitreomacular interface diseases, other macular retinal pathologies, and patients with DME who were previously treated with anti-VEGF injections were excluded from this study. Data of basic demographics, duration and treatment history of diabetes, best-corrected visual acuity and optical coherence tomography imaging were collected. BCVA and OCT imaging were done at baseline and repeated at 3rd and 6th month follow-up visits. Average inner and outer zone thickness of with diameters of 3000 and 6000 microns were obtained by averaging 4 inner and outer quadrants respectively, and changes were compared from baseline to 6 months. The Wilcoxon statistical test was used to compare the differences within the group, and p-value of less than 0.05 was considered as statistically significant. Coming to the results, 70 years of 64 patients were included in the study. Mean age of patients were 60 years and mean duration of diabetes were 15 years. 72% of patients had more than 10 years duration of diabetes. 93% of eyes showed good resolution of inner and outer zones thickness in OCT at 6th month follow-up visit. 14% eyes needed repeat laser, and 7% did not respond to focal laser and needed intravitreal anti-VEGF injections. Coming to duration of diabetes, 72% showed more than 10 years duration and 28% showed less than 10 years duration. 64% were using OHA and 36% were using insulin. Coming to the OCT parameters, mean central subfield thickness were almost similar in each visits. P-values not found to be significant. Means inner zone thickness as well as outer zone thickness showed a significant reduction from baseline to 6 months. P-value of 0.003 and p-value of less than 0.001 was noted, and it was found to be significant. So the graphical representation. And OCT and fundus photo of non-center involving DME following focal laser showed good resolution of edema. Some other case examples showing good resolution of NCI-DME following focal laser. Macular thickness map also showed a good reduction of edema. Coming to discussion, according to the current ETDRS guideline, focal or grid laser remained the first recommended treatment for NCI-DME. In our study, among 70 eyes with NCI-DME who underwent focal laser showed a significant reduction in inner zone as well as outer zone thickness at 6 month follow-up visit. Focal laser was found to be effective in 65 eyes with NCI-DME. A study by Scott et al. Found that at 1 year after the focal or grid laser treatment, mean visual acuity remained unchanged, while mean central subfoveal thickness reduced by 10 microns. They found the beneficial effect of reducing this retinal thickening in inner zone and outer zone also in volume measurements. A study by Pierente et al. Reported that focal laser treatment applied directly to angiographically leaking microaneurysm has a benefit of stabilizing the visual acuity and reducing the retinal thickening at 12 months compared to observation alone. The untreated eyes in the study had a significant increase in inner zone thickness. RESTORE trial concluded that macular laser treatment was as effective as anti-VEGF injections in patients with retinal thickness of less than 300 microns. Patients with focal parafoveal edema benefit from macular laser photocoagulation in terms of anatomical and visual outcome. Pradhana D et al. Reported that 72 patients with NCA-DME without any treatments, 26% progressed to center-involving DME by 2 years. A duration of diabetes more than 10 years was one major risk factor for conversion to center-involving DME. In our study, a majority of patients had more than 10 years duration of diabetes, and focal laser helped to prevent conversion to center-involving DME in 93% of patients. AIO's Diabetic Retinopathy Task Force and VRSI recommends observation for naive NCA-DME with good vision with monthly follow-up and focal laser for NCA-DME with BCVF less than 6.9 attributed to macular edema. In our study, we have calculated the changes in BCVA from baseline to 6 months, showed no statistically significant changes. Patients with BCVA of 6.6 also underwent focal laser, showed good resolution of NCA-DME with maintenance of vision. Smart India study by Rajiv Raman et al. Found the estimated national prevalence of vision-threatening diabetic retinopathy is 4%. In a population-based study in South India, the prevalence of NCA-DME was almost 3 times than that of center-involving DME. A low and middle-income country like India should be on the watch to detect and treat the sight-threatening NCA-DME before the vision is affected and before the need for more expensive treatment arises. However, there is a lacuna in Indian literature pertaining to real-world evidence in the subset of eyes with DME, and our study addresses this gap. Limitations: a lack of a control group to determine the conversion of center-involving DME, short duration of follow-up, and retrospective nature of the study. We concluded that focal laser is both an efficient and cost-effective treatment option for non-center-involving diabetic macular edema. Majority of patients had good resolution of edema in inner and outer zones of OCT. We recommended that in eyes with non-center-involving diabetic macular edema and a longer duration of diabetes, focal laser is to be strongly considered as a viable and effective treatment option. These are my references. Thank you.
I have one question. So, was your study, or the numbers of people who have been recruited for the study, was good enough? The number was good enough for the power for what you intend to do?
No.
What that could also be a limitation which you can add in your paper, right? So, what are the limitations you have in this patient? In your study, actually.
This was a retrospective study.
Apart from what you just mentioned.
We can include, if we are conducting as a prospective study, we can take more duration of diabetes to check for conversion to center-involving DME. That means we have taken only 6 months duration. So if we are looking for maybe a 5 or 10 years duration, and check into the conversion of center-involving DME, and we can find the effectiveness of laser.
Okay.
And
okay, thank you.
thank you.
So